Hello, and welcome to Mind, Mood, and Motion. I'm Amanda Apolloni, the Development Director for the Parkinson's Foundation Georgia chapter. Before we begin, I want to welcome those of you who are joining us for the first time and take a moment to share the mission of the Parkinson's Foundation. We make life better for people living with Parkinson's by improving care and advancing research towards a cure. To achieve our mission, we pursue three goals: to improve care for everyone with Parkinson's, to advance research towards a cure, and to empower and educate our global community. And we do all of this while building on the energy, experience, and passion of our global Parkinson's community. Here in Georgia, we support and collaborate with our two centers of excellence at Emory University and the Medical College of Georgia at Augusta University. We support local organizations through our community grants program and fundraising and awareness through our annual Walk for Parkinson's Moving Day Atlanta. We connect people with Parkinson's to a safe and effective fitness program through our PD Gladiator Fitness Network. While many classes have been suspended due to COVID-19, there are still Parkinson's fitness classes meeting in person and virtually to ensure that all of you stay moving. To find a class or personal trainer near you, please contact our local chapter. We have two exciting programs coming up, including Veterans with Parkinson's on Saturday, March 20th. Join us to learn more about the latest treatment advances with Parkinson's experts and hear from veterans who are now living with Parkinson's disease. On Friday, March 26th, we are hosting a Parkinson's 101 program in Korean featuring Dr. Eun-Jung Kang from NYU and local Parkinson's volunteer Hae-Jin Ban. Both of these programs are free, but registration is required. On April 22nd, join us for a virtual wine tasting and help support your local Parkinson's Georgia chapter. In addition to local programs, you can also participate in PD Health at Home virtual program series. Learn more and register at parkinson.org/pdhealth. We encourage everyone with Parkinson's to enroll today in our PD Generation Study, a national initiative that offers genetic testing and counseling at no cost to you. Participation can be either in person at one of our participating centers of excellence or from home through a telemedicine appointment and at-home cheek swab collection kit. Learn more and register at parkinson.org/pdgeneration. We would love to connect with you guys today. Visit our chapter website and follow us on Facebook for local resources and support, or call our toll-free helpline for answers to your PD-related questions. Before we get started, I wanted to thank today's program sponsors, Acadia, Adamas, Amneal, and Kyowa Kirin for their unwavering support. We invite you to learn more about these sponsors by visiting our chapter supporters page. It is now my pleasure to welcome our first speaker, Dr. Lazarus from the Multiple Sclerosis Center of Atlanta. Dr. Lazarus completed neurology residency training as well as a clinical fellowship of movement disorders at Emory University. He is currently a co-investigator on research collaborations between MSCA and Georgia State University. Dr. Lazarus, it's all yours.
Good morning, everyone. Thank you, Amanda. And I also want to thank Annie Long for inviting me to do this talk and being a part of today's program. I hope everyone can hear and see me clearly. The topic that I'm going to focus on today, the title for the talk is Mind, Mood, and Motion. And we're essentially going to focus on some of the less well-known aspects of Parkinson's, which are non-motor dysfunction, particularly the cognitive changes and the mood symptoms that can occur. And then some beneficial impact of exercise and activity in moderating not only the mood symptoms and the cognitive symptoms, but also the typical motor dysfunction. So this is my background. It's some relevant activity and disclosures. This is my office number, so I'm willing to take any questions, or if you have any help along the way, please reach out to me if I can help. And just as an overview, as an introduction, Now, our current approach to Parkinson's follows this template to some extent. It's a clinical diagnosis, as many of you know, which means that the diagnosis of Parkinson's is based on a typical history of symptoms that are still very contingent on movement issues and motor dysfunction. And then a range of therapies that, for the most part, often begun and hinged on pharmacotherapy. And there's a broad range of medications that we can use to ameliorate symptoms in Parkinson's. And then as an adjunct, we add different forms of therapies and different forms of support to our treatment approach and treatment paradigm. And that includes things like support groups, many of which are involved in today's program, or clinical trial participation to try to elucidate even further pharmacotherapies and also surgical therapies. And somewhere down the line, we tend to shift our focus to having an adjunct in terms of addressing the gait and balance problems that are quite prevalent in Parkinson's, or utilizing those treatment strategies, which are mainly physical therapy and exercise, to ameliorate some of the other symptoms. But hopefully, after today's talk, we can discuss why this paradigm has shifted so much, and our focus has also changed to incorporating these kinds of treatment strategies much sooner. I do want to emphasize that many of our treatment options, in fact, all of them, are really what we call symptomatic therapies. The goal of treatment in Parkinson's disease is to cover up the symptoms and to maintain function. We don't have any validated, proven treatments as yet that can slow down the pathology. That is the abnormal protein that accumulates in specific areas of the brain that we refer to as alpha-synuclein. But if we can develop and incorporate a successful enough therapeutic regimen that can hide the symptoms as best as possible and maintain function, then it becomes as close to a functional cure, at least a functional treatment as possible. And so that is the goal of any treatment strategy. Before starting to talk about an option for addressing cognitive changes in PD, I want to highlight what those are. And so we've known, like any neurological disorder that's progressive, that unfortunately changes in thinking and memory or cognitive changes are not uncommon in this disease population. And they tend to progress as the disease progresses, meaning as the burden of alpha-synuclein in the brain progresses, which we use a staging for called a BROC staging, and as other clinical symptoms tend to develop over time. We've often used the motor symptoms, so things like tremor or slowness or shuffling gait, as a really good surrogate of how well a patient is doing or how quickly or slowly the disease is progressing. But it's also very clear that non-motor symptoms, like cognitive symptoms, can be just as accurate and just as reliable as predictor or biomarker of the disease progression. And in general, when we think of neurological diseases, because of the progressive nature of debilitating disorders like this, they tend to progress from a very subtle or less severe kind of non-specific complaints, maybe in a Parkinson's patient, finding it difficult to string their thoughts together as quickly as they used to, and then leading to a title that we call mild cognitive impairment, which I'll describe a little bit later, and then dementia, which is often feared by a lot of patients and caregivers. Dementia, just to summarize, is just the term or the title we use when these memory and thinking problems really begin to affect day-to-day functioning and affect how much you can do from a functional standpoint. Now, when we think of cognitive changes, often they're very difficult and intangible to describe, and they can be very nebulous to understand as well. But fortunately, there are some good clinical tools that we can use to really pin down what type of cognitive challenges are happening from patient to patient, because they do vary so very much. And when we do that, we try to obtain a profile. This is true not only of Parkinson's, but when we're approaching patients with memory problems in general. And we do have certain categories of cognitive processes that we like to evaluate, which correlate really well with brain structure and with brain function. And here's a couple that are relevant to the Parkinson population. So we know, for example, that the process and the pathophysiology of Parkinson's can impact Parkinson's or patients with Parkinson's and their ability with regards to attention and working memory. Things like language or visual spatial function are well known to be obstacles for patients with Parkinson's. And there's noticeable decline in memory and executive function as well. So let's go through each of these in just a little bit of detail to try to paint a picture of what can be expected. So attention and working memory, often patients will notice just decreased attention and concentration. It can be very subtle. For example, early on, patients noticing that they lose track of following the train of a movie or while reading or repeating themselves during a conversation. And as things progress, they may turn into difficulty with juggling multiple things in one time. So multitasking can be quite difficult as well. The next is executive functioning. And a clear example of that would be difficulty in sequencing or multitasking, as I mentioned before. But that can also develop over time to trouble with organization or planning more complicated tasks, and switching your attention from one task to another, or just a difficulty in initiating activities, especially ones which were accomplished quite easily before. This is readily noticeable and identifiable in patients who had a very high pre-morbid or pre-existing level of functioning, but can be also noticeable in patients who have motor dysfunction and other kind of problems as well. Multitasking in PD is quite interesting and it's very relevant. The type of cognitive dysfunction that tends to develop is what we call a frontal cognitive dysfunction. And the speed and quality of both cognitive process as well as certain motor tasks are affected. And it's very interesting how this can affect patients' gait as well as activities called dual task activity. Dual task activity is something which, on a scientific basis, we use in clinical research to try to understand the processes involved. But from practically speaking, trying to have a complicated conversation or think of something in mind when doing something as trivial as walking can lead to increasing falls or increasing dysfunction. And so if you think of the cognitive processes that were at play prior to the onset of PD as autopilot, for example, things which did come very naturally in the past and very easily now require more effort and more time and may be more challenging to accomplish even in those circumstances. Memory issues are not foreign to the Parkinson's population. Most noticeably, short-term memory can be affected, and in a large percentage of people, actually, long-term memory remains relatively intact. Another aspect of cognition that can be impacted is language. And so it's not uncommon to have a phenomenon called dysnomia. So when patients have that kind of the tip of the tongue feeling, when they're thinking of the right words, but just finding the right context or bringing it out at the right time is more difficult than normal. And it can be quite frustrating, particularly in social circumstances. Of course, visuospatial function is often impaired in these patients. So the sense of direction, often not as dramatic as getting lost in familiar places or routes, but that can develop later on as navigating unfamiliar places become more and more difficult without help. And then misjudging distances and locations are something which patients tend to notice as well. So when we take these different categories or different aspects of cognition, neuropsychological testing or cognitive testing can be very useful to form a personalized individual cognitive profile or pattern about each of these aspects of memory and thinking are affected or if they're intact. And that profile helps us in a number of ways. One, it helps us to determine whether this fits with a typical pattern or typical profile that's seen with other patients with Parkinson's, or if perhaps there's something else going on that's potentially treatable or reversible. Second, it helps to tell us the severity in which each domain is affected and how we can follow and strategize to ameliorate the effects of that. And so it's really a useful tool on the basis of which often patients are described as having dementia. So the term dementia is used when there is progressive decline in cognitive function from the baseline level of functioning in at least more than one of the areas that we discussed. And a key factor here is that the level of dementia, the level of impairment impacts activities of daily life and social relationships. So it is when cognitive and thinking issues really begin to impact the function overall. So how prevalent is this in the Parkinson's population? There's a wide range of published reports ranging from 30 to 80% of patients with Parkinson's developing dementia at some point, but it's certainly not trivial and certainly not uncommon in this group. And there are certain risk factors which can increase the likelihood of patients with Parkinson's progressing to dementia. That includes the coexistence of another neurodegenerative disorder. So if a patient was to develop symptoms of Alzheimer's over and above dementia, for example, advanced age is another, certain family risk factors, for example. We also know that vascular risk factors, so uncontrolled high blood pressure or diabetes or high cholesterol, are all independent and also additive risk factors for the development of dementia. And there are also certain genetic risk factors, which we're learning more and more about all the time that may contribute. So I mentioned the type of profile that typifies Parkinson's dementia and how we use that to separate it out from other forms of dementia like Alzheimer's. I also touched on some of the risk factors, so I won't repeat this again. Things I did not mention was that in terms of the motor dysfunction, the motor problems that patients have, often we try to segregate them into different subtypes. One is called a tremor predominant. Another is when patients are less likely to have the tremor, but they're really characterized by slowness and stiffness. And in general, the memory and thinking problems, and therefore the likelihood of progressing to dementia is more common in that subpopulation than in those with pure tremor predominance. Now, in addition to the memory and thinking problems, often this can be accompanied by symptoms that we refer to as PD psychosis. And that can be a scary term, but really what it refers to is the presence of symptoms like hallucinations, in which there's distortion of a sensory experience. The most common is a visual hallucination. So seeing shadows or seeing things or people who are in the room, for example, or auditory hallucinations. Another phenomenon is called an illusion, where you're looking at a shadow, but now it starts to look like something different, and often something quite ominous and quite real, which isn't there. Again, there can be sensory illusions, like a sensation of someone walking past you, a sense of presence. There can be a little more vivid, like a visual hallucination. And in the beginning, these types of symptoms are identified as being a sensory illusion or distortion. And patients tend to retain insight. They're able to be cognizant of the fact that they're not real, but that can change as cognitive dysfunction and the psychosis dysfunction progresses as well. So when we are approaching cognitive issues, not only in Parkinson's patients, but in neurologic patients in general, we have a general template, a few principles that we like to follow. And the key is to exclude any transient or definitely any treatable causes of the altered mental status, things like urinary tract infections, pneumonia. It remains to be seen where COVID fits into this list, but reversible infectious etiologies or metabolic problems like dehydration and the electrolyte shifts that come from them are all very well-known factors that can contribute to changes in memory and thinking, particularly abrupt changes. Another important factor that we often look out for are medications or polypharmacy, bearing in mind that patients in this general health demographic are often susceptible to other medical conditions. And so polypharmacy, taking a long list of medications, it can be the norm rather than the exception. And any medication brings with it side effects or interactions can amplify that. And so excluding those treatable and transient causes, our next step usually is to try to simplify the medication regimen that we use, understanding that most of the treatments that target motor dysfunction in Parkinson's can carry with them a side effect of worsening either psychiatric symptoms or cognitive to some extent. But I want to emphasize as well the non-pharmacotherapeutic and the non-medication related approaches that we have. That includes, for example, maintaining a structured and familiar environment for the patient, something that's not easily done in a hospital setting, for example, or a skilled nursing facility. And then having a structured daily schedule to go along with that. Those kind of behavioral approaches and situational approaches can be very, very effective. We're going to touch a little bit on cognitive rehabilitation therapy as well. So there's several medication options that we can use, and I stratified them here according to the specific type of problem we're addressing. Generally with cognitive issues, things like Aricept and Exelon, which target a different neurotransmitter, acetylcholine in the brain, or Numenda, are used again as symptomatic treatment, unfortunately unable to probably slow down the process within the brain, but as symptomatic treatment for cognitive decline. In terms of psychosis, like hallucinations and delusions, they are a broad category of medications that we use, known as neuroleptics. And these are preferred options in Parkinson's because they are less likely to worsen things like tremor or the slowness or the shuffling gait. And Seroquel and Clozaril have been used for some time. Nuplazid, which works predominantly in serotonin and not the dopamine that's affected in Parkinson's, is also very useful in treating these patients. I'm going to touch a little bit on some of the advances we've had in understanding the kind of cognitive problems that characterize Parkinson's disease. This is a great paper that was shared by one of my colleagues at Emory, Dr. Higginbotham, from 2017, that helped to look at the profile of those cognitive impairments that patients in Parkinson's have. And if you really look at them closely, there's two big categories, two big buckets of problems they can have. One is what we refer to as a frontostriatal phenotype. It just refers to the pattern that we find of memory and thinking problems in the neuropsychological testing, in which there are deficits or problems with the executive function and the working memory. And in these patients, there's a deficit in the specific area of the brain, the frontostriatal striatal dopamine signaling. And they tend to respond to dopaminergic medications for that reason. A lot of these patients do not necessarily develop dementia. So the kinds of cognitive problems can remain stable or slowly progressive, and that's really important. In contrast, there's a second category called posterior cortical phenotype. And an assumption or hypothesis here is that these cognitive changes are due not only to the cortical, the Lewy body pathology that is seen in Parkinson's, but there's possibly a contribution from other abnormal proteins, such as the tau or amyloid proteins that we're seeing in the Alzheimer category of neurodegenerative disorder. And because the pathology in the brain is different, so too are the clinical deficits. And in the testing, things like language and visuospatial deficits can be affected very early on. And because the deficits are both earlier and more widespread in terms of the neuropsychological profile affected, they're slightly more likely to develop dementia down the line. There are a few gene variants that I mentioned here, the SCNA and the GBA, as well as a possible gene that's implicated in the processes involved in Alzheimer's, which are linked to this type of phenotype as opposed to the others. So a few non-pharmacotherapeutic options. One very relevant one is cognitive training. And that term just basically refers to regular and guided practice that focuses on very particular, very specific aspects of cognitive functioning. And there's good research now to show that this may prevent or even delay cognitive impairment or dementia by increasing what we call cognitive reserve. And so that often explains a mismatch between why someone has widespread pathology, for example, on certain brain scans, but their level of functioning is doing quite well. Is that the cognitive reserve or the brain substance, the brain function that's still disease-free takes on some of the role of the function that's lost. Many of these research methodologies are still new, and a lot of these research studies are still ongoing. So there is a paucity of large-scale placebo-controlled randomized studies, and placebo effect does play a role in this, but it's a challenging area to research for that reason. And there's a few other less structured studies that look at other forms of cognitive training. For example, there was one study that looked at the Sudoku and using computerized format, and that it improved certain tasks, for example, attention and memory, but not global cognitive function as a whole. One aspect of cognitive rehab therapy is that it tends to be individualized therapy based on neuropsychological testing and administered by trained therapists, such as an occupational therapist or speech therapist. And the goal of this is to address specific personal relevant goals. So it's not a generic treatment option. So let's talk a little bit about the mood symptoms that we mentioned. Hallucinations and illusions. This is a different type of psychiatric symptoms that's very prevalent in Parkinson's disease patients, both depression and anxiety, and there's a long list of symptoms which tend to overlap. They can also be misinterpreted as Parkinson's symptoms early on or vice versa. And so it makes it very difficult to sometimes confirm a diagnosis of either Parkinson's or the mood symptoms in pre-existing Parkinson's, and to treat these symptoms, but it can be very impactful both for the non-motor dysfunction and the motor symptoms like tremor and balance problems if depression and anxiety are controlled. A key aspect of depression in Parkinsonian disorders that slightly differs from other types of depression, for example, young onset depression, is something called apathy. So motivational issues that really can be central to a diagnosis of depression in Parkinson's disease. And there's key areas of apathy that can become prevalent. The most common is the behavioral apathy, but also cognitive apathy, in which there's slow cognitive processes. And of course, the emotional consequences of this, which is overt depression in itself. So as a whole, the mood symptoms are very common. About 80% or more of patients will endorse symptoms of depression or anxiety, and will have significant contributors to their overall quality of life and the overall level of functioning. And so that the impact is quite prevalent, not only on the patients themselves, but on their family. And if you look at the outcomes which we are trying to ameliorate or try to target in Parkinson's, which are quality of life, and that's really significantly impacted by the non-motor symptoms such as depression. And here are some of the other factors that tend to be impacted by uncontrolled depression and anxiety. So we know that physical and cognitive decline are just much more prevalent, and the motor symptoms are much harder to treat in patients with uncontrolled Parkinson's. And as a result, the rippling effect on self-care and the quality of life and family relationships are much really profound. If you look at healthcare indices like admission to hospital, or acute decline, they tend to be higher in patients with mental health issues that are uncontrolled. But much like the motor symptoms, we do have treatment options, and we do have strategies that help both cognitive and the mood issues in Parkinson's. And the big one that I'm going to focus on, that's really the title of today's talk, is exercise, and how different forms of exercise can be useful and is a useful adjunct to the pharmacotherapies that we spoke about early on. But let's look at why exercise first of all. Well, first, exercise has an impact that we call pleiotropy. It has so many diverse benefits on general physiology and general health that it makes a lot of sense to use this for neurodegenerative disorders as well. Yes, some of the non-neurologic as well as the neurologic benefits of exercise. We know this. There's just decades of evidence now that exercise and frequent and regular exercise can prevent cardiovascular disease. It can help to slow down the process of osteoporosis and improve bone health. What's relevant to today's talk and to today's patient population is that things like cognitive function, mood or depression, and non-motor neurologic function like sleep and fatigue can all be improved with the regular exercise. And it can also improve functional motor performance, which is very relevant in a patient with Parkinson's disease. And something that we focused on in the last few years, which is gaining some traction, is that patients who have a regular exercise regimen and an appropriate exercise regimen have at least some evidence of improved drug efficacy. They respond better to the typical drugs we use with questionable improved dopaminergic transmission. So they use the dopamine that's available more efficiently. And although not absolutely proven, there's some studies that are beginning to look at whether or not exercise in the right dose and the right frequency can have a neuroprotective effect, whether down the line we could try to use some of these strategies to actually slow down the process, or at least functionally slow down the process that's occurring in the brain. And so we really need to start thinking of exercise like we do of medications. There's different classes of medicines, and so there's different strategies, different types of exercise. And there's also different dosing of different medications too. And in a similar way, those are questions that we haven't quite answered yet, but we need to start thinking about. Because the overall picture and the bottom line is that we know that exercise modulates the overall disability in Parkinson's. So that if you look at the pyramid on the left, that at the base of both pyramids emphasize the motor dysfunction upon which there's secondary complications and a degree of disability that develops from Parkinson's. The peak of that pyramid is definitely impacted in patients who exercise. So we know that exercise improves brain function in many ways. One is a secondary impact of improving the cardiovascular and pulmonary function, to improve cognitive function as a result of those aspects. But in general, we also know, there's a wealth of evidence outside of Parkinson's that really hint that it improves brain function in general. So in healthy older adults, patients over 65, there are several studies now that really looked at the impact of attention and executive function and memory in patients who were exposed to exercise. In patients with Alzheimer's disease, also neurodegenerative proteinopathy, as we call it, there were improvements in certain cognitive processes. And in patients with mood dysfunction who did not have a primary diagnosis of Parkinson's, again, we noticed that there's improvements in working memory and processing speed, and also visual learning. So as a whole, the take-home message from this is that there is evidence that neurological function and dysfunction can improve with general aerobic exercise. And so if we extrapolate that to Parkinson's, there's also preclinical evidence now. For example, in animal models, those who are forced to exercise perform better on cognitive tasks than those who are sedentary. And in long-term, mostly aerobic exercise, if you really examine the neural structures of these patients, there was increased growth of neurons in the hippocampus that is very, very pertinent to memory, as well as increased release of brain factors that are involved in building new connections or synapses and certain proteins in the same function as well. More recent research has focused on the role of what we call epigenetic modification of two BDNF and GDNF. And so this is really an area of research that's ongoing. But I did mention that exercise, we have to start thinking of it like medication, just like there's different family or different classes of medicines, there's different type of exercise as well. And there's different doses. Well, speaking of BDNF, which is a neurotropic factor in the brain, one study looked at moderate intensity exercise, 45 to 60 minutes 3 times a week, and noted an improvement in executive function, and compared that to a different group which used progressive resistance exercise for a slightly longer duration, twice a week. And we noticed that there is an increased performance on cognitive tests, so increased cognitive function, but that the domains of cognitive function that were impacted differ between the two. And so if you look at randomized controlled studies of different types of exercise, the one that has proven to show some really good results is high intensity treadmill exercise, in which there was improved mobility as well as improved cognitive scores compared to moderate intensity and usual care. So putting this together, a take-home message is that vigorous exercise appears that it could have a neuroprotective effect, and that people with Parkinson's disease who had regular vigorous exercise had less cognitive decline after 1 year compared to those which had the usual care. And by usual care, we mean focusing on pharmacotherapy. There's still some ongoing long-term studies to support this, but this is the study from 2018 that stratified patients according to exercise intensity, which is measured by maximum heart rate during the workout sessions. So high intensity was defined as the 80 to 85% maximum heart rate, or moderate intensity is 60 to 65% versus usual care, which is either sedentary or just pure pharmacotherapy. And if you look at the change in the UPDRS motor score, so this measures really the motor symptoms predominantly, things like tremor and slowness and walking speed. There was almost zero change in the patients with high intensity exercise after 6 months who had stable medications. So none of these patients had their medication regimen changed during that period. In comparison, the moderate intensity group did have a slight change in the UPDRS score, so there was some progression in the motor symptoms, and there's generally accepted progression of motor symptoms in the usual care group. And in this study, there was a statistical difference, so there was a noticeable difference between the group in the vigorous exercise category and those with usual care. There are a few other registry studies that looked at larger populations of patients with Parkinson's. In a study of more than 4,000 patients with Parkinson's, 44% of that group did more than 150 minutes of exercise a week. 20% did less frequent, less than 150 minutes, and 36% did not incorporate a regular exercise regimen into their lifestyle. And the important findings here were that regular exercise led to better outcomes in terms of quality of life, physical function as measured by those motor scores, and less depression as well. And even up to a year later, the physical activity at baseline led to improved function on these indices. So not only is choosing the right type of exercise is important, for example, high intensity exercise, but this registry study suggested that the dose or how frequently or how much exercise is just as important. And this study found that 150 minutes of exercise tended to separate the two groups. So we can use a lot of key principles from studies looking at the general population, in that physical exercise is known to have a good impact on symptoms of depression and anxiety. And in fact, in some studies, the effect size, the strength of exercise is almost as equivalent as antidepressant medication. And many of these studies have shown that the type of exercise does matter. So vigorous exercise is likely to have a greater impact on mood dysfunction than it is moderate intensity exercise. And we know that the wealth of evidence so far has focused on aerobic exercise, but there's more recent research now that looks at things like resistance training as well, which could be additive. So putting these insights together, overall, if we're looking at cognitive dysfunction and mood symptoms, aerobic or resistance training, or even better, a combination of those two, aiming for 150 minutes combined a week of at least moderate intensity is known to have a good impact on enhancing mood. And the duration here, there should be no minimum duration, but in general, what I like to tell my patients, you would start to see the benefit for sure after 2 to 3 months. And so putting all this together, there's good evidence and there's good rationale, both from a biological standpoint, and here's some good reasons why. We know that exercise helps to reduce the chronic oxidative stress and the neuroinflammation that probably characterizes the disease. We know that it has an impact not just on the dopamine, but other neurotransmitters that are now widely affected in Parkinson's. And there's a question of neuroplasticity, the brain, the ability to recover from some of the damage that has been done. But on a behavioral level, it is so important to help us break the cycle of apathy and bradykinesia, which can become very devastating in the Parkinson's process. It helps certainly in terms of the psychological impact of the disease in gaining a sense of empowerment and control, and overall leading to a better outcome. Several forms of aerobic exercise have been examined particularly in its effect on mood and cognition in Parkinson's. Among these are aerobic exercise, which we looked at, things like dance therapy, Tai Chi, yoga has, as well as resistance training and strength training. Invariably, most forms of these exercise will have a beneficial effect. And the key important thing from all these studies is that they're feasible and very safe in this population. Something that we do bear in mind is that the patient population that are predisposed to Parkinson's unfortunately also have a higher incidence of things like cardiovascular disease and orthopedic disease. And so these are all very safe and feasible exercise regimens that have a good benefit on the Parkinson's disease itself. I'm going to highlight a little bit of data from two of these, aerobic training and then in yoga. These are two studies from 2014 in which patients looked at either cardiovascular and strength training combined. This was done in a group format over 48 weeks. And again, they had lower depression scores than patients who participated in non-structured exercise. And then just pure aerobic exercise in the form of continuous walking or interval walking for 45 minutes, 3 times a week. Again, at 6 months led to decreased depression scores, decreased fatigue, and overall improved quality of life. Similarly, many studies in yoga have followed the mood outcomes, looking at depression scores and anxiety scores. There were a couple of studies, and this is a paper that looked at a few of them in 2017. Here, there was a study that was done for a 12-week interim that looked at good improvement in depression scores in Parkinson's patients. And another study that looked at slightly older patients and a modified yoga program referred to as power yoga twice a week also saw decreases in depression. And then a more non-specific group in which there was an adaptive yoga program depending on the level of the patient's functional ability for about 8 weeks. So very similar results. So the bottom line is that exercise such as this seems to have a very positive impact on mood symptoms and very few side effects. It's very well tolerated. So a lot of details, much like when we talk about different classes of medications in Parkinson's and different side effects and different indications when to use which medication, it can become somewhat overwhelming. But the important aspects here are to choose the right type of exercise. And really the right type of exercise is something that you can stick to and be consistent with for a few months at least. And then to choose the right dose. And the right dose is you want to aim for roughly 150 minutes of exercise a week, in which is high intensity. So you really get the heart rate up and enough to feel fatigued at the end of the workout, but listen to your body for things like physical pain and exhaustion. So circling back to the paradigm that we often have used in addressing Parkinson's, when pharmacotherapy was the mainstay early on, it seems like it's become very relevant and very important to move things like exercise and rehabilitation and the principles that they bring and the benefit that they bring earlier on. And it's never too soon to start a structured exercise program, with or without a diagnosis like Parkinson's, but certainly in a diagnosis of Parkinson's. And I think that's if anything, is the take-home message here. A lot of the preclinical work particularly has hinted at how beneficial both exercise, both in the structured and unstructured sense, can have on the brain and the long-term benefits, as well as the safety of utilizing these programs. But as I mentioned, a lot of patients with Parkinson's have other limitations. For example, older patients may have cardiovascular problems or orthopedic like knee or hip issues that limit their ability to reach a high intensity, to reach that 80 to 85% heart rate and to benefit from that. And so it's really important to explore other treatment options that utilize the same mechanisms and have the same work in the same way as high intensity exercise. It could have the same benefit. And this is something under investigation right now. There's currently a study at Georgia State University, which is looking at a type of rehab called pertubation training. In pertubation training, subjects are subjected to unexpected falls while they restrain to prevent major injury. And this is done in the process of a walking treadmill over a 10-minute interval. The kind of premise behind this is these unexpected perturbations help to promote motor learning and motor recovery. And there's a wealth of data in other neurological disorders, particularly in multiple sclerosis and in healthy aging, that in repeated training with pertubation training, fall risk declines quite significantly. And the hope is that utilizing motor learning tools like this can help to impact fall risk in a Parkinson's patient. It remains to be seen that if exercise regimens such as the ones we have discussed also have an impact on non-motor symptoms like cognitive dysfunction or mood dysfunction, will tools like perturbation training also help to impact the non-motor symptoms like the cognitive dysfunction in those patients. And this study is looking at all of those outcomes as secondary measures. I did include the contact person who is a colleague of mine, Dr. Feng Yang, who's recruiting patients into that study now. So as a summary, we are aware that the common disorder that Parkinson carries with it both motor and non-motor dysfunction. In terms of the non-motor dysfunction, we focus today on cognitive and mood processes and the very specific issues that can occur in Parkinson's disease that unfortunately can also change over time. We also hinted at the hallucinations and dementia that can coexist, but spoke about new ways to approach these that are not pharmacotherapeutic. There's always a template in mind. We will always want to exclude new medication changes, infections, or other health issues that are contributing to these issues in Parkinson's patients. But we really focused on non-pharmacotherapeutic options and highlighted the benefit of exercise that it has both on motor outcomes in terms of mobility, but also the relevant non-motor outcomes like cognition and mood, and ultimately quality of life, which is what we're trying to impact in treating Parkinson's as a whole. And I've mentioned this a couple of times, but to reiterate, the right dose of exercise, so to speak, you want to aim for about 150 minutes of aerobic exercise a week, which may slow down this course of PD. I want to thank you for inviting me again, and thank you for your attention. I'm going to leave my contact information up if I can be of any assistance to any patients, and I'm open to any questions that may have come up.
Awesome. Thank you so much. Yes, we have a couple questions that came through, so I'll go ahead and ask them. So question number one is, are there any medication treatments for apathy that could help me get my spouse to exercise? I know exercise would improve his mood, but I can't seem to get him motivated.
Yeah, that's a very good question. It becomes somewhat of a very difficult cycle to break because apathy itself can be impacted by exercise. Exercise can do so well for apathy and vice versa. And apathy can be a symptom of depression. And you're on the right track in trying to get an exercise program as a way of addressing that. We often use medications like antidepressants. I showed an image earlier on of something called a frontostriatal pathway, and that's impacted in depression as well and does cause a lot of apathy. Certain categories of antidepressants, particularly in Parkinson's, can be very effective, even when there's no overt depression, when there's no crying spells or anhedonia, loss of interest in things, or insomnia. But if there's pure apathy, antidepressants can be a safe way of being an adjunct to an exercise regimen. And in more advanced cases, we try to stay away from stimulants, but they can be very helpful as well. But for a large percentage of patients with Parkinson's, just replacing the levodopa tends to be a dopamine responsive symptom, at least early on. And replacing the levodopa, finding the right dose of Sinemet or dopamine agonist can reverse a lot of those symptoms.
Awesome. Thank you for answering that. Question number two is, how do you deal with sudden changes in temperature in the body? Sometimes when my mom gets hot, she gets confused and doesn't know where she is.
That's a great question, and unfortunately not uncommon in Parkinson's. Now, there's two answers to that. The first is Parkinson's predisposes to something called autonomic dysfunction, which is the ability to regulate the body temperature itself. Can be a feature of the disease, but unfortunately, patients with Parkinson's are prone to infections, which is really what we worry about in patients with a fever, even a subjective fever. So the very first step would be to exclude things like a urinary tract infection or pneumonia. And unfortunately, in the current climate, COVID as well, that would be the very first step because those are really treatable and treatable in a very different way. There's specific treatments for them.
Thank you. Question number three, are there any non-pharmacological medications that can be used in conjunction with the pharmacological ones that help with mood and or cognition? Example, CQ10 and melatonin.
Yeah, that's a really good question. And there's a broad range, a really wide variety of non-FDA approved supplemental medication, which may or may not help in Parkinson's. Because they're not approved, a lot of them don't have good data behind them, but I can tell you the ones that have some data. Melatonin, for example, is very useful in addressing not so much the mood symptoms, but the insomnia that can lead to mood changes and lead to fatigue and exacerbate cognitive problems, and it's quite safe. CoQ10, unfortunately, has been investigated, for many years, and the studies were not too favorable. And there's different questions about why that is. Was it a dosing issue, or was it the way the study was designed? But there's really not great evidence to warrant all patients, or me to recommend it to all patients right now. At this time, the mainstay of my approach, making sure that things like vitamin deficiencies, like vitamin D deficiency, for example, are well treated, making sure that insomnia and fatigue are treated both with supplements, as you mentioned, like melatonin, but behavioral changes, having exercise and physical therapy, either structured in forms of physical therapy or less well structured in terms of independent exercise, be the mainstay of any non-pharmacotherapy regimen. And then adding small doses of medication just to complement the behavioral and the lifestyle changes that come with everything we spoke about.
Thank you. Our question number 4 says, my wife has bad constant dizziness, headaches, and morning fogginess. Is this from her meds?
It could be. A lot of the medications have an unfortunate side effect of dropping blood pressure slightly. And in general, not just in Parkinson's, that can be more common in the morning. And so a slight drop in blood pressure can lead to mental fogginess, as you mentioned, or headache. But so too can things like sleep apnea, which is very common in the general population and can have those exact same symptoms. I would definitely discuss this with your physician, but something that's easy to do would be maybe to take the blood pressure the first thing in the morning, and to look out for things like fatigue late in the afternoon or an early morning headache, both of which can be reflective of something else going on like sleep apnea.
Our question 5 says, I have heard of a practitioner recommending, and I'm probably going to say this wrong, so I apologize,
Okay.
Cetosine to increase medication efficiency. It supposedly works by increasing the number of levodopa receptors. Is there a long-term risk or benefit to PD patients of increasing number of dopamine receptors?
That's a good question. So I think acetylcholine, maybe acetylcysteine, is that what they were referring to?
It's
acetylcholine.
Yeah, sorry, go ahead, Amy.
Acetylcholine.
Okay. That's a really good question. There were some preclinical studies, again, in a mouse model that showed that the dopamine receptors would increase when they were given certain compounds like acetylcholine. But that hasn't as yet translated into showing that patients actually do better, even the animal models do better in terms of better motor control, or where are they 5 years down the line in terms of quality of life or functional ability. And because of that, and we don't know really well the long-term safety data, it's hard to really recommend them. One of the safety issues that we would worry about is the interaction with other medications. And a lot of commonly used Parkinson's medicines, the dopamine agonists like Requip or Miripex, for example, and the cognitive medications like Aricept, do have a lot of drug interaction. So that would be my biggest concern about adding that on too soon without really large-scale clinical trials in patients who are taking those medications.
Thank you. Sorry, I pronounced that wrong. Question 6 is, have you had the opportunity to review integrated medicine or naturopathic treatment options to improve the quality of life for people with Parkinson's?
That's a great question. There's several studies ongoing now, which we are reviewing, looking at naturopathic medications. CoQ10 has been under investigation for some time. So has resveratrol. Resveratrol is another antioxidant, which unfortunately does not seem as promising more recently. There are quite a few studies looking at CBD oil and more recently THC oil. The THC studies, at least in the state of Georgia, have been delayed because of COVID, unfortunately. But so far, nothing really sticks out yet beyond ensuring that there's no vitamin deficiency, number one. Things like general health measures, so vitamin C and zinc can be helpful in patients when there's a pandemic going on, for example. And then melatonin is probably the only naturopathic medication, which I mentioned previously, but it's also very specific. And it really only benefits patients who are having difficulty with sleep or insomnia, or the syndrome called REM behavior disorder, when patients tend to act out their dreams at night. So administering to patients who don't have those symptoms don't really yield a benefit. They don't notice much change either way.
Your answer kind of goes into the next question here, so that's perfect. Question 7 says, is CBD safe and effective for mood disorders for Parkinson's patients?
It's a really good question. I can tell you the data we have in non-Parkinson's patients, which is why there are now studies occurring in Parkinson's patients. In general, it seems to be safe. The problem being, because it's not well regulated, it's not FDA approved, there are many distributors and manufacturers. So there are few, which I don't have on hand, but I can get, which seem to be safe. The caveat here is that this was investigated in healthy patients who tend not to be in a lot of medications. And the key questions we don't have in Parkinson's yet is, does CBD oil interact with levodopa, with the cinnamate? Does it impact the dopamine agonists? Does it reduce their absorption or increase their absorption? Or does it compete in the brain for the same place where it's acting? We just don't have a good answer for that. Overall, from a health benefit, it seems safe, and it seems very inconsistent, even in general population or in the older population, and whether there's a benefit or not. So almost 10 years ago, there was a study looking at CBD oil and its impact on tremor in France. And the first study showed possibly it might help tremor, but when they expanded it and improved the patient population to a much larger sample, it seemed to be diluted out, and there wasn't much benefit in the tremor. And the only outcome they really looked at in that study was tremor. But several groups have voiced the optimism of THC oil, which is not regulated in Georgia as yet, and a study for THC oil in Parkinson's. So that's definitely something to follow over the next few months. COVID has impacted recruitment into those clinical studies and how we can do them quite significantly. It's not a priority for the Georgia Senate right now, but hopefully we can get that going before the end of the year too.
Question 8, do you recommend exercise to all of your Parkinson's patients, regardless of their symptom severity? Are your exercise prescriptions different person to person?
That's a good question. The short answer is yes, absolutely. So there's no reason where I wouldn't recommend exercise. The only exception being immediately after a cardiac event, if someone had a heart attack or a stroke or a major surgery like hip replacement, we would adjust the timing, and it's generally not more than 2 to 3 weeks. And I generally do that in conjunction with a cardiologist. But every single patient really should be on an exercise program. And it doesn't matter whether it's structured or unstructured. What's important is that the type or the category, so to speak, of exercise is something that's engaging and interesting, because then you'll stick with it, and that the dose is right. And so in general, remember, all studies are to some extent a generalization, because we're making a broad statement based on different groups of people. In general, you want enough of a dose, you want enough frequency to be like 2.5 hours a week or 150 minutes. But I definitely adjust that based on a patient's level, their baseline functional level, and other health problems. Someone who's young and healthy and already active, for example, I would want much more than that. And I would want to emphasize something like resistance or strength training if that was their major motor concern or their major deficit. For others in whom cognitive problems are probably the biggest impact, or apathy is the biggest impact, then I tend to shift my focus more to aerobic exercise, because of all the data we've seen that aerobic exercise has such a profound impact on non-motor dysfunction. So it really should be a personalized approach. And this is where experts like physical therapy, and we have a colleague straight after me who will be speaking, are so useful, because physical therapy sets you up with a personalized plan that then has really good benefit that you can build on later on down the line. It's much like the complicated medication regimens we have in Parkinson's. We're up to so many different categories of diseases, so many strategies of dosing, whether it's 2 or 3 times a day or just at night, so many different formulations and doses. We really have to start thinking about exercise in that way. It's the same, for example, with surgery. There's different types of DBS surgery, different types of stimulation. Well, exercise can be and should be as complicated and as individualized as that, because it can be as beneficial as that.
Awesome, thank you. The next question says, I have balance issues, so it is difficult to stand without assistance. I want to be able to ambulate between the wheelchair and a walker as long as I can. I already exercise 5 times a week. Is that enough?
That's a very good question. The short answer is there really is no maximum amount to exercise. The maximum limit is what your body is telling you in terms of pain and fatigue. And we know that exercise also improves fatigue, but it takes some time to get there. It really depends on the type of exercise in terms of improving mobility. So when it comes to mobility issues, such as ambulatory issues or walking problems, This may be the time to start adding in other forms of exercise like resistance training or gait training in addition to your usual workout routine. And so it may not be how much you're working out, because it sounds like you're hitting a good dose there. It just may be the type of exercise. And this is where having some assistance like a physical therapist, I think, would be very useful.
This is a follow-up question to something you answered earlier. It says, what is the max dosage of melatonin, and when do you recommend people take it for the maximum benefit?
So the best time to take melatonin is probably an hour to 45 minutes before bedtime. And the dosing starts at 1 milligram, usually 3 milligrams is the lowest effective dose. You can go up to 12 milligrams of melatonin. It's really quite safe. I would say increase the dose weekly, so not sooner than every week. Don't make a change until a week later, because you want to give it enough time to have benefit. And so those are really the key things.
Question 11 says, can you repeat what you stated with regard to the use of vitamin D and the effect on it with people living with Parkinson's?
That's a good question. So the effect of vitamin D on the processes in Parkinson's itself is really not very well known, but we know that vitamin D impacts certain processes in the brain that can influence things like depression and influence things like anxiety, and to a lesser extent, cognitive problems as well. A lot of this work was done at Emory by Dr. Marian Everett, but it's also very important in today's context in terms of immune functioning and general overall health. So whereas vitamin D replacement in a patient who has normal vitamin D may not be very relevant, in patients who have slightly low vitamin D, replacing vitamin D in those Parkinson's patients are very important to reduce the risk of things like osteoporosis, to reduce the risk of falls, which they are at risk of anyway, and to help improve mobility. And as a side note, things like fatigue and mood can be modulated to some extent by replacing vitamin D.
Awesome. So our final question here is, what would you tell someone who is newly diagnosed regarding exercise to ensure that it's incorporated immediately after diagnosis? What would be your elevator pitch?
Exercise has what we call pleiotropic impacts on the brain, and Parkinson's is no different. Pleiotropic means it has such diverse impacts on heart function, lung function, and brain function that it's hard to characterize them all at once. But just like medication, exercise needs to be very thoughtful in the way it's planned, and so we need to find the right dose, which is about 150 minutes a week, with the right frequency as well. So that's 150 minutes, the right dose being the right intensity, and you want high intensity exercise, and the right category of exercise, which really depends on the patient. But this is the mainstay, the lifestyle change that's going to prevent the progression or slow progression of Parkinson's.
Awesome. Well, thank you so much, Dr. Lazarus, for that. That was incredibly informative, a lot of wonderful information. So for everybody, we're now going to take a quick brain and breath break with Valeria Gary, a speech language pathologist and a certified personal trainer.
Well, looks like we don't have volume, so maybe we will take a quick break to figure out the volume. But we do want to keep everyone around because we're going to hear from Benchmark Physical Therapy in just a minute.
Hi, I'm Valeria Gary, and I'm a volunteer with the Parkinson's Foundation. I'm also the owner of Southeast Parkinson Speech Services. And today we're going to exercise the muscles that are involved with speech and voice. This is important because it is not unusual for people with Parkinson's disease to have complaints about difficulties with speech and voice. If you have some concerns, you should be seen by a speech language pathologist, and particularly if you have some voice concerns, you should be seen by an ear, nose, and throat doctor. So today we're going to exercise the muscles in a way that is gentle yet effective. And so when people think about making their voice louder, there's a tendency to concentrate on the muscles in the throat and to try to squeeze out a louder voice. But that's not what we want to do. We want to use the whole body approach to getting a stronger voice. So it all is going to start with posture. So make sure that you're sitting up nice and tall, that the ears and the shoulders are aligned. The head is straight up. So imagine that there's a string at the top of your head, and that string is going straight up to the ceiling. It is not going to the wall. Okay. This is important in order to get good breathing and good voice. So let's start with the breathing. So we're going to use the muscles of the diaphragm to help power out our voices. Let's put one hand on the chest and one hand on the belly. And as you breathe in, I want you to feel the belly expand. It's going to come out. And as you exhale, as you breathe out, the belly is going to come in. So imagine that you're breathing the air into your stomach, and your stomach is full of air when you breathe in. And then that air comes out as you exhale or breathe out. So let's do 2 breaths together, in through the nose and out through the mouth. That's 1. That's 2. I hope you noticed that my chest hand did not lift up. We're not using these muscles in order to breathe. We're using these muscles. Now, the next area where we're going to get some powerful voice is using the space that's in our head. So put one finger on each side of the nose, and we're going to hum and feel the vibration. Did you feel that vibration? Now we're going to hum, and then we're going to open the mouth to produce an ah sound. We want to try to keep the vibration in the head space. I'll do it first. So I felt that vibration. I opened my mouth wide to get more voice out. I didn't do anything with the muscles here. All right, so let's do it together. Big breath in from the belly. How did that feel? Did you keep the vibration? Did your shoulders stay down? All right, let's do it again. Big breath in from the belly. All right, now we're going to stretch and contract the vocal cords. When we go to a high note, we're stretching them. When we go to a lower note, we're contracting them. We're going to glide up on ah like this. Ah. Now you'll have your own starting and high note. Let's do it together. Ah. Now let's go from high to low. Ah. Do it with me if you haven't already. Ah. Let's do one more up and one more down. Ah. Ah. Now, how about we throw a little brain exercise in there? So I've been using my fingers to gesture low to high and high to low. Let's try the opposite. I'm going to gesture this way, but your voice is going to go that way. So if I gesture from high to low, you'll go low to high. Ah. And if I gesture low to high, you'll do the opposite. Ah. All right, so I'm not going to do this along with you. I'm just going to move my hands. Go the opposite way. All right, so we throw a little brain exercise in there because the brain likes a little challenge and a little stimulation every once in a while. So I hope you enjoyed these exercises, and I hope you keep moving everything every day. Thank you.
Thank you so much, Valeria. It's now time to introduce our final speaker, Hannah Ghosh, who's the Clinical Director at Benchmark Physical Therapy. Hannah, take it away.
Thank you, Amanda. All right. So I'm going to be talking today about the benefits of exercise and physical therapy for persons with Parkinson's. And I know that Dr. Lazarus just spoke a lot on this. And so some of this will overlap, but I have some different things in here for you. Here's a little introduction to myself. This is my family. They're so cute. I had to put them in there. I have a 2-year-old daughter and a 6-month-old son. I went to Emory for physical therapy school. And
sorry to interrupt. Would you be able to click that share screen button? We aren't able to see your
Oh
screen.
my goodness, I am so sorry.
No worries, thank you.
This will help a lot, I promise. Okay. So now you should be able to see this. Yes?
Yeah, perfect, thank you.
Okay, so then here is the cute picture. You couldn't see this before. But I have a 2-year-old daughter and a 6-month-old son. And I am a geriatric certified specialist from the American Board of Physical Therapy Association. And so I practice with older adults in Dunwoody, just north of Atlanta. And I've been treating patients with Parkinson's for over 3 years now. So I switched my slides around. I thought we would do a little bit of exercise first before we go through some more slides. So I can't see everybody, but I would like everyone to get ready to stand up. I'm going to scoot my camera away for a second. Let's see. Scoot my chair back. Okay, so I'd like everyone to stand up. Okay, for some of you, that was probably really easy, but did anybody have trouble with that? Did you have to use your hands to push up from your chair, or did you have to attempt to do it multiple times in a row? Or did you lose your balance once you stood up? If the answer is yes, we're going to try it a little differently. So now what I want everyone to do is I want you to reach for the ground when you stand up. So you're going to take your hands, you're going to do a big scoop, reach for the ground, bend forward, and then stand up tall. Okay, and then when you sit down, you're going to do a big scoop, reach for the ground, and then sit down slow. All right. If that was a little bit easier, that's because we're using your momentum to get you to lean forward and get your weight over your toes. That's sometimes very difficult for people with Parkinson's to bring your weight, shifting it forward. Okay, so I want to try something here. I want everyone to stand up. And then we're going to sit down, but I want you to sit down halfway. Don't sit down in your chair yet. Just hold it. 1, 2, 3, 4, 5, and then sit down. Good. And then stand up halfway. Hold it there. 1, 2, 3, 4, 5, and then all the way up. And then you're going to sit down halfway again. Hold it right before you sit down. Hold it, hold it, hold it, hold it, hold it, and then have a seat. So that was just a little warm up, you guys. If that was easy, good for you. Keep doing what you're doing to keep your legs strong. If that was difficult, this is something that you can definitely practice every day. Getting up and down from a chair is something we need to do every day. So this is something really good to practice. So that's just to get you guys moving, get your minds firing. I wanted to touch a little bit about how physical therapy and exercise can help Parkinson's disease. I know Dr. Lazarus just went through a lot of these points. So there's a lot of words up there right now. Take a look at it and think if you can identify anything on the screen right now that you would like for yourself. Who would like improved balance, improved strength, endurance, safety, mobility, and improve getting dressed in the morning. So exercise alone can help with a lot of these things, just like Dr. Lazarus talked about, but specifically physical therapy can help improve your magnitude of movement, improve your dual tasking, standing up from a low surface like a couch or toilet. In physical therapy, you'll focus a lot on decreasing risk of falls, decreasing your fear of falling, improving getting up and down from the floor, improving daily tasks such as picking up objects from the floor, walking and moving without freezing of gait, and what to do if you do have freezing of gait. So Every person with Parkinson's has a different presentation. There are common characteristics, but what you may be struggling with is not what your neighbor is going to be struggling with. So physical therapy sessions are specifically tailored to each person and their specific goals. Okay, so Dr. Lazarus touched on this as well. What type of exercise is best? The best exercise would include aerobic training, progressive resistance training or strength training, balance training, and stretching. So stretching is so important with Parkinson's due to postural changes that include people getting more forward flexed, they're losing rotation in their spine and reduced extension in the spine. And so all of these can affect your gait and your balance down the line. So if you can stretch to counteract those changes, that is very beneficial. And Dr. Lazarus talked a lot about aerobic exercises, but it can also improve tolerance to activity, cardiovascular system, have a neuroprotective effect, improve your cognition, your lung capacity. And then strength training or resistance training is so important to maintain your functional mobility, including getting up and down from a chair, getting up from the floor, and especially balance. The biggest predictor of balance is going to be how strong your legs are, especially your hips. So if you don't have good balance, we need to look at your strength in your legs and see what we can do to improve that. So strength training for one person is going to be very different than strength training for another person. For someone who is more deconditioned, strength training could be doing bridges in bed or doing sit to stands from a chair. For someone who's has less deconditioning and has been strength training their whole life or is very active, that would include lifting weights at the gym or doing the leg press. So exercise is very personalized. And I'm just going to take a note. Amanda mentioned earlier the PD Gladiators Fitness Network. It's in Metro Atlanta. And I'm just going to say a little bit about that. They have such great classes, including non-contact boxing, yoga, spin classes. So if you want to go to a class and be around other people who have Parkinson's so that you can have a little support group with it too, it's a really fun way to get your exercise in. And then you have people to support you and encourage you. And so to get started with exercise, like Dr. Lazarus said, talk to your doctor. If you're having any cardiovascular problems, any heart problems, you want to get that cleared first before you start exercising. And then if you talk to a physical therapist, especially one who knows about Parkinson's, then we can talk about concerns you have with exercise and set up a good program that's tailored to you. You want to change up your exercise routine to stay interested. And like I said, going to classes with friends and buddies can keep you accountable and make it more fun. So just a little note from my life, I'm trying to get in more exercise, right? I'm a mom of 2 kids and it's hard. But the last 2 days, the thing that I've been doing for exercise is dance workouts with my 2-year-old. She just wants to listen to music and dance. And so it involves jumping, spinning, twisting. My heart rate's getting up. And so something that you like to do, it doesn't have to be sitting at a gym on a bike. It could be anything that is enjoyable for you that gets you moving and gets your heart rate up. Okay, so now I'm going to talk a little bit more about physical therapy. So some common misconceptions that you might hear about physical therapy is that one is it's too early for me to do physical therapy because my Parkinson's isn't bad enough yet. So at the beginning stages of Parkinson's, you may have changes that you don't notice that are still happening. A skilled physical therapist would be able to pick up on those changes, and they might be differences in balance between your left and right leg, difficulty dual tasking. Does your walking speed change when you're carrying something or when you're carrying on a conversation? Decreased step length is something they might notice, and they might notice some strength deficits that can lead to problems later on in life. So if you're having any changes, It's never too early to start PT. Just have someone get their eyes on you, and they might say, well, you don't need a full plan of care physical therapy right now, but come back in 6 months and we'll do all these same tests and see if you have had any changes. If you think you haven't fallen, so you don't need physical therapy, you need to know first, if you have had any falls, you need to get into a physical therapist to help prevent more falls. And if you've had, same thing, if you've had any narrow escapes with falls. And even if you haven't fallen, we can help with any other problems that you're having. So if you're having difficulty picking something up off the floor, or if you're having difficulty getting up from a chair, you're having difficulty walking, or even if you say, my friends are noticing that I'm not moving as smoothly as I have before, and you want to change that, anything, a physical therapist can help you with that. Some people might think physical therapy is going to hurt, but truthfully, movement decreases pain. So if you're having stiffness and soreness in your back and muscles, getting moving and getting your muscles stronger will help decrease your pain. And then we'll also work on posture. A lot of pain comes from poor posture. And so if we work on your posture throughout therapy, that should also help with your pain. If you think you'll be on the machines the whole time when you're in physical therapy, you're definitely wrong there. We may utilize machines at certain times during your session, but most of our sessions are very hands-on. We're right next to you. We're cueing you the whole time, telling you to pick up your feet, to spread out your feet, to straighten your back, or just keep reminding you on what to do as we're doing the physical therapy. And if you feel like you can't do anything about your walking or freezing, that it's just part of Parkinson's, we have strategies to improve your gait. We have strategies to improve your freezing, and we measure your progress every few sessions. So you say, I'm having this problem. We take a baseline measurement. We try and work on it a few days in a row, and then we take a remeasurement and see, look, we've worked on this for 4 days in a row now, and you are doing much better than you were on Monday. So we will check your progress the whole time. So what to expect at your physical therapy evaluation. So when you come for your first visit, we will provide a lot of information to you. We will also want to get a lot of information from you, such as what medications you're on, what exercises you've tried in the past. And then we'll ask you about what you're having trouble with at home. What are your goals, and what do you want to focus your treatment on? And then we'll provide information on support groups, movement disorder specialists, websites you can go to, local events, just like the Parkinson's Foundation does. And then there's something called LSVT Big treatment that I will talk about in the next slide that we can provide you information on and that you might participate in, or your doctor might want you to participate in. And then we'll talk about your plan of care, which is how many times we want you to come to physical therapy a week and for how many weeks, and we'll set goals with you. And then we will assess how you are doing with walking, standing up from a chair, turning, getting up and down from the floor, looking at your speed, your balance, your strength, your coordination. So these are things that a physical therapist will measure all in your first visit. Okay. And I mentioned LSVT Big, and what that is a research-based exercise program that a physical therapist or an occupational therapist will do with you. And it's teaching people with Parkinson's how and when to apply extra effort to produce bigger motions. So Parkinson's is telling your brain to do a motion small, and you trying to override it by trying to do it very big, what ends up coming out is normal. So the whole point of LSVT Big is to help recalibrate your brain and movements to be normal amplitude. It's also helpful when you're looking for a physical therapist to look for a physical therapist who is LSVT Big certified, because you know then that that therapist will specialize in treating Parkinson's disease. So maybe you don't want to do the LSVT Big program, but if you find a therapist specialized in LSVT Big, you know that that therapist specializes in treating Parkinson's and that they will be able to help you specifically. And then I wanted to talk about what to expect at your follow-up sessions with physical therapy. If we are doing the LSVT big protocol, we have a set of specific exercises, including stretching, stepping forwards, sideways, and backwards, turning, twisting, and bending, and then standing up from sitting. And then from there, we add on specific functional tasks specific to you. And if you've done LSVT big before and you think, there's no way I could do that, I've gotten worse, we can make it easier. Or if you've done it before and you thought that was way too easy for me, I'm way more advanced, we can also make it harder. So you can do the program laying down or sitting if you're wheelchair bound or bed bound. You can do it standing blindfolded, standing on foam, holding weights. All of those are ways that we can make it harder. And then the other things we'll do with your physical therapy sessions is we'll focus on your individual functional tasks that you want to work on, which for everyone, we're going to work on walking, but picking up a dropped object, unloading the dishwasher, walking on an uneven surface, buttoning a shirt, getting a walker in or out of the car. Those are just examples. What you might want to work on is going to be different. What someone else will want to work on could be getting up from the couch or helping pick up your grandchildren. Whatever is important to you is what we will focus on during your physical therapy. So I believe that is all that I have for you today. So I'll turn the time back to Amanda for any questions that anyone has.
Thank you for doing all of that. Let me see here. So I don't know that we have any specific questions, but one thing will be, what are some good exercise video sites for Parkinson's workouts that somebody could do from home?
That's a great question. I know the the PD Gladiators network has online classes. And so I'm not sure, I haven't looked through YouTube, but I'm sure there's going to be some Parkinson's classes on YouTube. But if you want to join an online exercise class, and there are at-home exercises that Danielle just posted in the chat, getting involved in an online exercise class is going to be really important, and it'll keep you accountable to actually doing your exercise routine. So check out
Absolutely.
the PD Gladiators Fitness Network. There's some boxing classes, there's some yoga classes, there's some seated chair classes. So it's a really great network.
Thank you. And we did just have a question come through. If you were on a beta blocker for tremor, what heart rate should be your goal in an aerobic exercise?
So being on the beta blocker will affect your heart rate. You're correct. You won't see your heart rate go up as high as someone else who is exercising. So you want to monitor your other symptoms, such as shortness of breath and how much you're sweating and exerting yourself. So you should feel like you're working moderate to hard. And you should be able to carry on a conversation while you're exercising. If you're unable to get out multiple words at a time, that you're having to stop and catch your breath like that, then that's a little bit too hard of exercise. So you want to monitor your ability to talk and monitor how much you feel like you're exerting yourself rather than your heart rate.
Thank you. A second question came in that said, could you talk about vibration/power plate therapy for PD patients?
I don't know too much about the vibration. I've not had personal experience with it. So I can't really talk to that specifically, but I'm sure there's some good research out there. I'm sorry.
No, thank you. Question 3 says, do you have to be referred by a doctor to go to PT? What if my neurologist doesn't think that I need it? Should I find a new doctor?
I think almost any neurologist that treats Parkinson's patients will give you a referral to physical therapy if you ask him. If you're in the state of Georgia, you can come to physical therapy for 8 visits without a referral from a doctor. However, if you have Medicare, you will need the referral from the doctor. So legally we could treat you, but if you want your insurance to pay for it, you need that referral from your doctor if you have Medicare. If you have a different insurance like Blue Cross Blue Shield or Cigna, then you can come without that referral from your doctor.
Good information. Thank you.
Mm-hmm.
Question 4 says, is pickleball safe for me? I have mild issue with balance.
So without having seen you specifically, it's hard to answer that, but I think pickleball is a really great sport. It's not going to challenge your balance too much, and you're not going to be tripping over your feet as much as you would with tennis. And so if you can play it safely without stumbling or tripping over your feet, then I would say, yes, you should keep playing it because it's something that will keep your heart rate up and it's interesting to you, then I would keep doing it. But if you find you're having trouble with that and you want help continuing to play pickleball, then that might be time to talk to a physical therapist and talk to them about that specific goal, and we could work with you to keep you playing pickleball.
Another question is, who should do LSVT big? Are all of the visits safe to do right now during COVID?
So I know that in our benchmark physical therapy clinics, we're taking extra precautions because of COVID. So we're all keeping our masks on. Every patient who comes in has to wear a mask. And then the LSVT big program is one-on-one. So it will be just you and your therapist in close proximity to each other. Who should do LSVT big? It's a great program, and it's tailored towards people with Parkinson's. And so anyone with Parkinson's who hasn't done it before, I think it's a good thing to try out. If you are in the middle of the program and you're thinking, this is not for me, this is not going well, talk to your physical therapist and you can try you can move from that to do a different program instead.
Great, thank you. The next question is, what qualifies someone for in-home physical therapy sessions rather than outpatient?
Okay, so that is determined. You have to talk with your doctor about that. If you cannot get out of your home safely, and the only reason you are leaving your home is to go to doctor's appointments and essential businesses, such like even you can't go grocery shopping on your own, then that would qualify you for home health care if the only reason you're leaving is for doctor's appointments. So if you are able to leave your home and go to the grocery store or go to a restaurant, then you would not qualify for home health care. You would need to come to outpatient physical therapy. Did it answer all of that question? Was there a second part?
I think that was the whole question. Thank you.
Okay.
And then the final question here is, should everyone with Parkinson's plan to see a PT at least once a year?
I think that's a really good idea. I know my friend Amanda treats Parkinson's in Birmingham, and she's been doing it for 6 years, and she has people come in for checkup appointments. So every 6 months or every year, depending on how severe their Parkinson's is, she takes measurements that she can compare to the 6 months prior and says, look, over the last 6 months, you've gotten a little worse on your balance. I want you to focus more on that at home. Or she can say, look, you've gotten better. So your exercise routine is working great. So keep doing that at home. So it's something that I think is very useful and I think would be a great idea.
Awesome. Well, thank you. Well, those were our questions. This was very informative and great information. So thank you so much, Hannah.
Thank you, Amanda.
So on behalf of the Parkinson's Foundation Georgia chapter, I want to thank all of our presenters for their time today. We also want to thank all of our attendees for joining us. Thank you again to our program sponsors, Acadia, Adamas, Amneal, and Kiowa Kirin for their generous support. We invite you to learn more about these partners and their Parkinson's therapies by visiting the link in the chat. Today's program was recorded and will be sent out next week. If there were any questions that were not answered today, please call our toll-free helpline at 1-800-4PD-INFO. Thank you guys for joining, and we will see you next time.